Good morning, students. Today we're going to focus on our lecture on child abuse and neglect. Before we begin into our lecture slides, let's go ahead and look at Module 11 for child abuse and neglect. As you can see, we have an introduction to begin the module. Then we have the accompanying lecture slides. I do not foresee any changes that will be made on this lecture slide except for the content that talks about submitting an oral presentation. Just omit that part as that is not applicable to the summer course. Other than that, everything is exactly the same. So that's why I will not be changing or putting up an updated lecture slides. We also have our two main documentaries that are posted in Module 11. The first one is Slipping Through the Cracks, and the second one is America's Child Death Shame. Each of these are 30 minutes apiece. And we also have a discussion post that is posted for this documentary as well. We have 3 articles for Module 11. This is a very heavy topic, and I have tried to find as many supplemental resources relevant to the content that will be helpful for increasing your exposure and knowledge in the content area. The first one is talking about developing genital herpes in children, and that's the mandatory article. However, the next 2 articles, although optional, are also very good in terms of expanding on this knowledge. The second one talks about the long-term consequences of child abuse and neglect on adult economic well-being. So you can really see children who have gone through traumatic experiences as a child, specifically abuse and neglect, and abuses of all kinds, sexual, physical, emotional. How does it really impact their overall success rate and their economic well-being during adulthood? The third article, which is also optional, is from the Journal of Child Psychology and Psychiatry. It talks about the resilience and building of resilience in children who have been maltreated in the past, in the present, and it basically gives you an annual research review. So this is looking at several research articles and giving you a comprehensive review of how does the resilience really differ in children who have been maltreated. Again, both of these articles, although optional, are great for increasing your exposure in this content area. Let's go ahead and get started with our slides for this week. Okay, so in this lecture, I want to first go ahead and get started with the definition of what is exactly child abuse. And that is the harm or threat to a child's health or safety by a person who is responsible for their health and safety. And it includes, I want you to place emphasis on this word, non-accidental physical abuse, neglect, sexual abuse, or exploitation, or emotional abuse. Many times when we talk about child abuse, specifically looking at the physical abuse category, it's very important to realize that many of these are meant or shown as accidental. In fact, they're very much non-accidental. So it's all kinds of non-accidental abuses. And it applies to any child or individual under the age of 18. Now, you may be thinking that, what about the older teenagers, perhaps within the age bracket of 15 to 18? How would they be subjected to child abuse, especially knowing that they are able to defend themselves, they're able to report, they're able to do several things that could protect them from that abuse and neglect. And unfortunately, in many of the situations, we do see that children who find themselves in fact helpless, even though they're able to defend themselves and are able to report. You're going to see that depicted in a case study where a 17-year-old teenager boy committed suicide because of several episodes of physical abuse and neglect, and unfortunately was not able to really communicate or speak about that abuse or neglect to anyone, and then ended up committing suicide. And that is why we say that this is, when we talk about child abuse, we're not really looking at the age categories or age brackets of younger children. We're looking at everyone under the age of 18 because it does apply to everyone under the age of 18. Furthermore, a person responsible for a child is defined as one who's responsible for the child's health or safety, and they could be in several different forms. Usually we tend to look at, parents or legal guardians, but they could also be in the form of foster parents, a person 18 years of age or older with whom the child is cohabiting, and that can include several people. It could be extended family members like uncles, aunts, cousins, siblings, brothers and sisters. It could be also any other adult residing in the home. Several times there are extended family members or even family friends who cohabit with the child in their same home, and the abuse could be coming from any one of those figures, and we're looking at all of them. Looking at the epidemiology for child maltreatment, So just a little note, the word child maltreatment is going to be used interchangeably with child abuse and neglect, both of them meaning the same thing. I wanted to show you some data from 2006 from the U.S. Department of Health and Human Services. Now, although it's from 2006, this data is still pretty current, still very relatable. And it's looking at the overall number of reports that are submitted each year. So 3 million reports are submitted each year that are involving around 5.5 million children. And from those just mere reports, we have about 902,000 confirmed cases of abuse and neglect each year. When we look at what kind of rate that puts us in, usually the rates for epidemiology are determined per 1,000 of units. So in this case, it's per 1,000 children. And it puts us at a rate of 12.1 children of confirmed cases, 12.1 confirmed cases of abuse and neglect per 1,000 children. When we further look at the categories, we see about 18% cases that are of physical abuse, 64% cases, so an overwhelming majority cases of neglect, and then 9% cases of sexual abuse. We're going to look at specifically what do we consider or what is considered neglect. And there are some more specific subcategories to be discovered and discussed under that. However, let's look at this last piece of information, reports that are submitted by medical personnel, and only 8% of the reports from these big figure right here are actually submitted through the medical personnel. Now, it's important to note that this broad category includes everyone from, a clinic, a pediatrician, hospital staffs, ER staff, to the school nurses and the school health staff. So what we're really looking at is, even though children go to school every day, they come into contact with the school staff and administration, possibly schools, nurses, and other healthcare staff that might be employed at a school district, only 8% of those are really working to report on these numbers. And there are several factors that are involved, and we're going to look into those in detail in today's lecture, and some in much more detail in the ethics and policy lecture for tomorrow. But the point being is that this number should be a lot higher than 8%. In fact, it should be about 60%, 70%. The higher the better, because that would allow us to see that every child in America, in Texas, that goes to school is under observation by not just their teachers or the administration, but also the school's healthcare staff, the school nurses, and thus they're noting and taking notes on those things that are happening, not just the child's behavior, but everything else that might be going on with the child, and are part of this reporting system. And what really it does is it strengthens our infrastructure that has been built for reports, for reporting, and for really taking care of children. At victimization rates by each age group, and I really like this graph because it's divided the entire data into 5 particular age groups. And if you look at the victimization rate per 1,000 children, in the first age group, we're looking at a rate of about 16.1 per 1,000. Then it drops down to about 13.4 for the age group of 4 to 7 per 1,000. Then 10.9 for children ages 8 to 11. 9.3 for children ages 12 to 15, and then to 6.1 from children aged 16 to 17. So you see this clear trend where as the child gets older, the victimization rate decreases. That also allows us to see that the first age group, with children from less than age 1 up until 3, are the most vulnerable to abuse and neglect. And there could be several reasons for that. I mean, the first one being that this is also the group that is completely dependent on those who are taking care of them. They're unable to speak about the abuse and neglect. They're unable to raise a voice. They're unable to inform others other than what is visibly seen from the injuries that are caused by the abuse and neglect. And as we see, another thing that is important to note is, as a child gets older, the victimization doesn't necessarily just go away. For example, we would think that an 8-year-old would be able to talk about some of the abuses if he or she may be facing at home. Now, why is it that the child does not necessarily speak up to others around them? And then that, being the point of investigation and stopping that abuse and neglect from occurring. Why is it that it's continuing to happen? Even though it's decreasing, it's continuing to happen as a child is getting older. And that is because there are several other psychological factors that are involved, such as scaring the child, punishing the child, threatening the child, with the death of their own or their beloved family members. So there are several other things that are involved, which kind of enables a child to become better at hiding the abuses and neglect that are occurring at home, not talking about it, completely restricting conversation around it, avoiding it. And therefore, even though it's decreasing, it's still happening because children are also getting smarter, and there are other psychological factors that they're engaging in that prevents them from really approaching those around them to talk about this. So we have to look at it in both aspects. When we look at perpetrators, those who are responsible for inflicting this pain, causing this abuse and neglect, contrary to the popular belief, and this happens in every session, in every semester, where students think that it would be that the high majority of the perpetrators would be outside of the home. It would be extended family members, relatives, school staff, child daycare provider, myriad of other people who come into, or other roles who come into contact with the child. However, the reality is that parents are responsible for 80% of the cases. So 80% of the times parents are identified as the perpetrators, and then other relatives mark up about 6.7%. If you look at this pie chart right here, it gives you specific percentages for every other role, and what percentage of those individuals are responsible for causing abuse and neglect, such as foster parents. A lot of times the popular belief is children who live, and I mean, of course, it is backed up by evidence. We do look at studies that are backed up by hardcore evidence, but looking at this pie chart, foster parents are responsible for about 0.4% of the abuse and neglect. There's another reality to that as well. A majority of the children do live with their parents. They don't live with foster parents or other relatives or in facilities and things like that, and that is why those numbers are lower for them, whereas this number is a lot higher for parents, because majority of the children do live with their parents. Now, fatalities, as abuse and neglect leading to death of children. So what does the data say about that? And I've included pie charts for all of these, really to help you understand and to help you comprehend what exactly does the numbers and the percentages means. For me, I'm a visual learner, so it really helps to see numbers being displayed in a graph or a nice chart, or it helps with memorization as well. So I encourage you to look at both of those formats. With the fatalities, we are looking at about 1,500 deaths each year. That those numbers have grown and they have increased, and that puts it as a rate of 2.4 deaths of children at all age groups per 1,000. So when we look at specifically children from different age groups, that number changes. Looking at this pie chart right here, so specifically children from the age of 1 up till 3, that number changes to 81%. 4 till 7, 11.5%, 8 till 11, 4.1%, and then 12 till 17, 3.4%. So 45% of the deaths that do occur as far as abuse, as a result of abuse and neglect, do occur in children less than 1 year of age, and that is our age group. Like I said earlier, that is the most vulnerable and completely dependable on their caretaker. 78% of the cases, or 78% of the fatalities occur in children that are less than 4 years old. Okay. Looking at specifically in infants, that puts us at a rate of 18 deaths per 1,000 children. So when you compare it to the overall fatality rate of 2 deaths per 1,000 to 18 deaths per 1,000, that has multiplied by times 9 when we're looking at specifically infants. So that tells you that as the age group gets younger, the rate of fatality gets incredibly higher, especially if you're looking at this part of the pie chart where you have 45% of the deaths that occur in children less than 1 year. Children that are of 1 year of age, 14.6%. 2 years, 13.2%. 3 years, 8.2%. Altogether, this number makes up between 78 to 81%. It's also important to look at the types of maltreatment. So we're looking at physical abuse, we're looking at sexual abuse, we're looking at emotional abuse. And then, like I said earlier, we're going to look at specific kinds of neglect cases. So we're looking at physical neglect, educational neglect, medical, and then lack of supervision. So our lecture is going to go over specifically these forms of neglect. Let's look at physical abuse. And I want to go ahead and inform you that some of the graphics that are included in the lecture are very disturbing. So just be aware of that. I understand that it's a very sensitive topic. In my face-to-face lectures, I allow students to walk out of the classroom if something is incredibly sensitive or if something is incredibly upsetting. For you, what I can offer is if you are, as you're going through the lecture content, as you're going through this video, if you find something that is very upsetting, pause the video, take a break, go ahead and take a walk, and then come back to it. I do want you to go ahead and complete the content because it will really allow for the accompanying lecture slides to make sense and put context to it. So don't skip the lecture altogether because you're afraid of going through that. You can pause it at several events and come back to it. So looking at physical abuse, we're looking at bruising of any kind, especially on the following areas. So face, throat, upper arms, butt, thighs, lower back areas. And although it is usually, expected is it's going to be in the form of a hand slap, like fingers are going to be printed, like in this particular graphic right here, they could be in unusual shapes as well. On an infant, specifically, we see it in formats of clusters where there are several injuries that are occurring in one particular area together. So it could be in the face area, it could be in the scalp, it could be on the arm, where there are a whole bunch of injuries in different healing processes in clusters. We'll also see through case studies bites and pinch marks where there's a deep pinch mark where a nail has kind of gone through the skin and that has caused that injury. So you're able to see those two fingernails embedded into the skin and you're seeing that injury in a healing process. You're also seeing bite marks. Important thing to note in physical abuses is that they're often in various stages of healing, and that is how it indicates abuse, that it is not just a one-time thing or it can't be masked as an accidental abuse. If it's in various stages of healing, it's a continual process that's been happening at different time periods, and that is a very clear way of indicating physical abuse for a child. If you notice right here, so these are cigarette burn marks right here for a child. And in this little boy, if you see this particular mark right here compared to this one looks very fresh, very recent, whereas this one looks a little older, quite far into the healing process. And the same over here where when we talk about different areas where physical abuse occurs, we're also looking at pulling hair. We're looking at twisting of the ear to the point where it can hurt the internal ear canal or even cause bleeding or tear of the cartilage. We're also looking at choking, so choking marks around the neck area. When we look at burns, there are several different kinds of burns that occur, so it's very important to be aware of all of those. Cigarette burns being very common, and again, burns are just one of the subcategories of physical abuse, and it's very important to cover those because several of the case studies from the Department of Family and Protective Services, social workers' offices, specifically go into detail about the kind of burn, when it happened, the pattern, what item or object was used to cause the pain. So when we're looking at burns, where cigarette burns are very common, specifically in the feet or the abdomen area. If you look at this particular graphic right here for this child, you see that there are several marks of cigarette burns, and they've occurred at different stages. You can see that these two are pretty recent. In fact, all three of these are pretty recent, whereas these are a little older and they're in the healing process. We're also looking at immersion burns, and what exactly are those? And those are like dropping a baby or a child into a hot water. Sometimes immersion burns are unfortunately also occurred through oil, and we see that as well. We also see rope burns, so you can see that right here in this particular case study, and these are burns in shapes. We're also looking at burns in shapes of common household utensils, irons, flat irons, and things like that. I understand it's difficult to go through these images, but unfortunately this is a reality. It happens far too commonly, and it's very important, specifically for all of you who are going to be in a health field in some way or some form, whether it be as a teacher, as a PA, as a nurse, a pediatric nurse specifically, a school coach, a athletic department's director, whatever your role may be, you're going to come into contact with children, with adolescents. So it's very important to be aware of these characteristics, of these formats and the patterns, the way physical abuse, neglect, sexual abuse occurs. It is applicable to all roles, to all professions. We're also looking at unexplained injuries. So a lot of times in case studies that I've seen, injuries are oftentimes marked as unexplained or accidental, or don't know how it occurred. The parent was another part of the house, or the perpetrator, more correctly used the term would be perpetrator, was in one part of the house, and then the child was another part of the house, and they have no idea what happened to the child, and then the child had some form of unexplained injuries. That is often the language that is used in many of the case studies, but it's very important to be aware of what are some of these very common unexplained injuries are, specifically in case studies that have been proven to be cases of abuse and neglect. So skeletal injuries, twisting, fractures, dislocations within the arms, where a child, broke the leg getting off the stairs, or they broke their arm, they got it stuck into the crib, or they got it stuck into the staircase. Missing or chipped or loose teeth, tearing of gums, tearing or injury on the tongue tissue. Loss of hair, especially in forms of patches, because that is a very clear indication of a patch of hair that has been pulled as a form of aggression. But you can see it in this particular graphic where hair has been pulled as a result of abuse and physical aggression. We're looking at broken eardrum, retinal hemorrhages, and then also abdominal injuries in cases of punches, being slammed against the wall, and things like that. Now, it's important to be aware of not just the physical signs and symptoms, but also behavioral indicators of physical abuse. And especially very important when we're looking at older children, because in the younger children, if they come into medical attention, if there are clear signs and patterns, they should be recognized, and further steps should be taken. But what about children who are a little older, who are afraid, who are scared, who are afraid to speak to anyone? As they're growing older, they're getting better at hiding those signs and symptoms of physical abuse, yet it still occurs every single day. So there are some very clear behavioral indicators among those children that we need to be aware of to make sure we're able to use those and recognize them. So first of all, behavioral extremes. If a child is usually very happy and very go-lucky, or whatever the norm may be, the behavioral norm may be for the child, as soon as they go through an episode of abuse, all of a sudden the child is acting completely not within their behavioral norm. And they're displaying behavioral extremes. They have an inappropriate fear of a parent or a caretaker, and I want to add, or whoever the perpetrator may be. Now, that can be in the form of a parent, it can be in the form of a caretaker, it can be in the form of a teacher, it could be anyone, right? Anyone who comes into contact with a child is a potential. And having an inappropriate fear of exposing or facing that individual, that's a sign. Unusual shyness or wariness of physical contact, and now we're not looking at the regular shy personality. We're looking at an unusual shyness or really extreme amounts of anxiety that are depicted when there is any form of physical contact that is initiated. Let me be more specific. For example, a handshake, a hug, where a child is afraid to do that because they're afraid they might get hurt in the process, especially if that's been the norm of their abuse and then neglect. We're also looking at antisocial behavior. The child is not engaging in social settings with peers within the classroom. They're, demonstrating a very antisocial behavior. They like to hang out by themselves. Reluctance to return home from school among young children. So specifically, if that is occurring at a home, the child is very reluctant to go back home, or if it's occurring at school or any of the other settings, they're very reluctant to go to that setting, especially, for example, let's say if a child is really afraid of going to a specific relative's house, whether it be a grandparent, an aunt, an uncle, where perhaps any kind of abuse could be occurring, and they're very reluctant to going to that location again and again due to this fear of being abused again. Disclosure of abuse is a behavioral indicator, and when you watch the documentary, you're going to see and come across one particular case study where a child was very open about what was exactly going on, and yet there was lack of initiative and lack of timeliness as far as the initiative was concerned from the authorities, and that costed that child his life. So when there is a disclosure of abuse, although we know that children, are sometimes very exaggerative with the stories they make, it's still enough to be looked into, to be further investigated. And if that comes out to be not true, then that's that. But at least further investigation should be done. It shouldn't be considered a mere figment, mere imagination of the child, because they're young and they tend to make up stories. We're also looking at depression. We're looking at symptoms of depression occurring as early as children between the ages of 2 to 3, and we've talked about this in rather detail of how symptoms of depression can come about, especially if you have a parent who's suffering from depression, some maternal postpartum depression, and then also if a child is going through physical abuse. There is an attempt to hide injuries, and how so? Wearing long sleeves, especially if the bruising or the physical injuries on the arms or in the very visible areas. Attempt to make stories. We tend to see that especially in older children, school-age children, middle school children, where, oh, I fell off the stairs, and it's the same kind of pattern. It's like similar stories, a little bit of differences, but it keeps happening over and over and over, and there's a pattern to it. So that's definitely a point for further assessment. And then lastly, that a punishment is deserved. A lot of times there are psychological factors that are involved. In fact, many of the times there are psychological factors that are involved to keep children quiet, to discourage them from speaking to others about what's happening. And amongst those psychological factors, one of them is that a child deserves punishment, and that's why they go through what they go through. And unfortunately for a child, it might be very difficult to differentiate that from really logically analyzing what's happening to them. So if a child really starts to display behavior where, certain behavior or certain consequences in life happened to them because they deserved it, then that's a point for further assessment. We also see slowed mental, physical, and emotional development that is accompanied by withdrawal, aggression, regression, anxiety, low self-esteem. Depression can oftentimes turn into suicidal thoughts, and we see that happening in one of the documentary's case studies. We say that the child tells you that they're being injured, but the explanation of an injury changes, and then that's why it's not believable over and over. Also, when a child wants to abuse a pet or an animal in a similar way that has been occurring to them, that's a cause. That's something to be looked into, where they're extremely abusive to a pet or an animal. Not something that's a behavior that would not be considered normal, and then perhaps really looking into why that child is displaying that particular emotion, or why are they feeling that need to do what they're doing to that pet or to that animal, and perhaps looking further into that. All right. Now let's go ahead and look into sexual abuse and some of the signs and symptoms of sexual abuse. The first and foremost, and I've made it into red text, so it's really important, is somatic complaints that are including pain and irritation of the genital area. Oftentimes in younger children, they would complain about how their private parts are hurting, and especially if they've recently gone through an unfortunate episode of sexual abuse, they would complain that, oh, I'm having trouble peeing, or I'm having trouble sitting, or I am having just a pain or irritation in my genital area. Now, for older children, especially after puberty, if we're looking at really early pregnancy, especially in children who are in middle school at the age of 11 or 12, that has been proven through case studies. Upon further investigation from the child, that has oftentimes also resulted or has been identified as sexual abuse. We're also looking at bruising or bleeding from the genital area or the anal region, a genital discharge with a foul odor at a very young age, and then frequent unexplained sore throats, yeasts, urinary infections, and in very extreme cases, and especially if it's a recent episode, torn or stained bloody underclothes. Now, patients younger than 6 years of age were more likely to have genitourinary symptoms than the older patients, so that's why I put it in red text, because it's important to realize that a higher amount of our sexual abuse cases do occur in younger patients, in younger children. So it's very important to realize what kind of signs and symptoms are affiliated with that particular age group. The act of sexual abuse causes physical damage to the female pelvic anatomy, and then that manifests itself later in the gynecological or genitourinary symptoms. Another direct effect could be the acquisition of a sexually transmitted infection that may remain hidden until adult age. We also have, other hypotheses that relate to the psychological consequences of childhood sexual abuse. And there are many studies that have suggested that severe stress caused by the abuse could actually reduce a child's immune system or immune status and in the victim, and then increase their vulnerability to further diseases. So they'll be more likely to get the colds and the flus because their overall immunity is reduced due to the stress that is caused by the frequent episodes of sexual abuse. So those were the physical symptoms, physical signs of sexual abuse. What about the behavioral indicators of sexual abuse? First of all, victim disclosure. If there is a 3-year-old or 4-year-old who comes across and says, I don't feel comfortable in my private part, I'm having, all the physical signs and symptoms, with an additional note of so-and-so touches me in that way and I feel uncomfortable. Now, the language may not be the same. The language may be, very confused, where a child actually doesn't know what's happening, and thus their speech is very confused in that aspect. But putting 2 and 2 together, that's considered victim disclosure, and that's definitely a point of further assessment and further investigation. Unfortunately, that does not happen. Unfortunately, we let those slide. We let them think as a mere imagination. We let them think as a child exaggerating. We let them think as this just fear of not wanting to go to school, a fear of not wanting to go to a certain person's household, a fear of not coming into contact with the parent, not going home, and thus, therefore, it goes unnoticed. However, victim disclosure is the most important behavioral indicator of sexual abuse and should be used for further assessment. I can't stress that enough. Number 2, poor relationships, where a child is unable to forge, what would be considered normal relationships with their peers, with their teachers, anyone who's not a perpetrator. Child's relationship with those individuals are impacted because of what's happening because of what's happening with the perpetrator. We're also looking at regressive behavior. So if a child has, gone through the stages of potty training, if they've gone through the stages of, feeding themselves, they're kind of going back, or they're unlearning some of the behaviors that they have learned, some of the milestones that they have accomplished. And we've talked about the developmental stages and the milestones in much detail, and how establishing those at the right time and at the right age are so important, because if a child goes back, we're able to see, okay, this child is displaying, characteristic regressive behavior. Some examples are bedwetting, thumb sucking, fear of the dark, especially if a child has accomplished or overcome a certain fear. And then, going back into that fear, that's an indicator. We're also looking at sudden behavioral changes, especially if there has been a recent episode of sexual abuse, then the child starts to really display some of the repressive behaviors until they're able to overcome that. And then there's been, some time that has passed up until the next episode, or, whatever the case may be with the child. We're looking at promiscuity in older children who are much more interested in, sexuality, who have more knowledge of sexuality, who are engaging in that behavior because they consider that to be the normalized standard. We're also looking at older children, specifically teenagers, who are engaging in substance abuse as a way to cope with stress and the harm and the injury that's caused by the sexual abuse, and the emotional. There are also difficulty walking or sitting. In younger children, we see a preoccupation with the sexual organs of everyone who is a non-perpetrator. So it could be a parent, it could be a teacher, it could be other children, and sexual organs, and asking questions in that regards are much more informed. So, educated questions, that's what we call it in scientific research. So having context allows you to ask educated questions. So in younger children, when they have that knowledge, that advanced knowledge that is deemed inappropriate for their age about sexual organs, about sexuality, about sexual functioning, and then asking further, more elaborative questions on that, that's definitely an indication of what exactly might be going on. And that kind of leads into the last thing: unusual and age inappropriate interest in sexual matters, and asking much more elaborative questions which could be, okay, well, how did you know about this in the first place, or this particular aspect of it in the first place? So just being more aware of it really helps us realize those behavioral indicators among children when they are unfortunately occurring. Neglects and things to consider. So within neglect, I earlier told you, I'm just going to go back a few slides of what exactly neglect comprised of, and that was physical, educational, medical, and lack of supervision. But before we even consider or start talking about neglect, it's really important to address a very sensitive topic, and that is of cultural norms. What may be neglect in one culture may be normal in one another. And I want you to think back to the first lecture when we talked about the infant co-sleeping patterns versus sleeping by themselves. We talked about different examples in different cultures where co-sleeping was considered normal and was actually appreciated and was considered a good thing, versus sleeping individually was considered, a building of independence, and so forth in other cultures, and how that variation was okay. That variation was completely normal. So what I want you to consider is, when we talk about neglect, it's really important to first look at perhaps it can be an aspect of cultural norms. And I'll give you more specific examples as we cover more content. I also want you to consider the financial responsibility to provide. And sometimes, well, in today's day and age, it often relies on both parents who end up working full-time. We're coming to a day and age in America where both of the parents are kind of expected to work full-time in order to provide a comfortable lifestyle for their children. And if that being the norm, we're looking at less time that is available to spend with family, for children specifically. So because of this this financial responsibility to provide is there, that often times translates as less time. So it's something to consider before we start to look into specific aspects of neglect. So indicators of neglect. First and foremost, abandonment. I have a very specific story that I shared with my classes, face-to-face classes, and that is how exactly could abandonment happen. I had a student who was doing an internship in the Dallas-Fort Worth area, and she had shared the story with me a few semesters ago, where she talked about how she was driving back from her internship to her residence, and she was going through the suburb where there was like a gated community, and right outside of the gates, she saw a child in her diaper who was, just kind of hanging out in the front area, in that little island of grass patch. That child was just hanging out over there by themselves with no adults nearby. So the student saw that, and she was like, that was pretty odd. So she circled back and she drove around. She came back and she saw that there was actually no cars nearby. So it wasn't even like, a car had broken down, a parent was nearby, and they were just waiting for help to come. That child was by themselves in that area with no one nearby. Well, turns out she calls the police, and when the police comes, they do further investigation, and what they found out was that the child did not even live in that neighborhood. He did not even live in that gated community, so it was not even like there were parents inside and they just, left the child outside. Whatever the reason may be, it wasn't even that. That child was actually put in the car seat, strapped, buckled up, and driven to a location, dropped there, and then the parent drove out. And unfortunately, that's how abandonment happens. And this is pretty recent, and it's just one of the millions of stories that occurs where children are left and abandoned in homes, with caretakers, with other individuals, at schools. And it is a very clear indicator of neglect, where when the child is left abandoned or unsupervised for a extended period of time, it could be a few hours, it could be to a few days, where a caretaker is not helpful in initiating or in contacting or in providing contact. That's a very clear indicator of neglect. We're also looking at chronic unsavoriness or poor hygienes, so it can be in the form of untreated scabies, diaper rash, bad sores. So it seems like it's a very chronic condition where the child keeps developing the same thing over and over, or what they have developed that's not been taken care of in a timely manner, especially if it's, for example, like a diaper rash. When that happens, the child is really reddened skin and experiences a lot of discomfort. They're unable to wear a diaper, they're unable to walk properly, they're unable to sit properly, urinate properly. So there's several things that are associated with just a mere diaper rash. But if it's not taken care of in time, and taking care of a diaper rash is applying that Destin cream to it, letting it soothe, making sure that the child wears light clothing, in that time. So not taking care of that in a timely manner can really impact the child's overall functionality. The point being that if it's a chronic condition, it probably keeps happening over and over and over, and then that's an indicator of why is that happening over and over. Is the child not being kept clean and hygienic at all times? What could be going on? So it's a further point of assessment, point of investigation. When I keep saying indicators, it's important to still use those as a point of indicator, but not to assume it's an automatic neglect. Why? Because you never know what else could be going on at the other side. So that's why it's important to take these and use this as point of investigations and further assessments before you come to a conclusion. Next, unsuitable clothing for the weather. So it goes both ways. In cold weathers, you know, sending a child to school or to daycare in, you know, summer type of clothing, light clothing, rather than, you know, making sure they have their jackets and their sweaters and their hats on. Looking at untreated illnesses or injury, excessive sunburn, or other factors that would indicate extreme exposure, lack of immunizations, which would be a medical neglect, or when child is left unsupervised repeatedly or in a potentially dangerous situation. So just for your information, I included a shot schedule for an infant right here, and that includes everything from hepatitis B to hepatitis A and everything in between that should occur. And it also includes at what age should the shots be given. So you have the 2-month age, you have the birth, you have your 12 months, you have your 18 months. So you're looking at all of those. I also wanted to add additional behavioral indicators of neglect. So problematic school attendance, where, you know, truancy is skipping class, but when there is a problem with a parent taking the child to school, and not being very regular with the attendance of the child, coming in late, oftentimes they're unprepared, they're often hungry, the homework goes undone for several episodes, for several days. Chronic hunger and tiredness is also a very clear behavioral indicator. We're looking at substance abuse. We're also looking at a child that is assuming adult responsibilities beyond their capabilities at a very early age. We're looking at reporting no caretaker at home, where a child finds it normal to not have a caretaker at home at a very young age. So we're not looking at, you know, your older teenagers like 15 or 16. We're looking at younger children like, you know, maybe 7 or 8, who often report that they don't have anyone to take care of them at home, and they take care of them by themselves. And in fact, there have been several cases of these where those indicators were used as point of assessments, and found out that actually the parent was not at home at those times. In fact, no one was to take care of the child. That brings us to our next topic of emotional maltreatment. Emotional maltreatment is actually a little tricky, because oftentimes the emotional or the mental injury it causes can easily go unrecognized, especially if the professional or the one who gets in regular exposure to the child is not aware of those. The effects of emotional maltreatment is to handicap the child, and it actually is lasting rather than temporary, and it is observed in a child's behavior. So what are some of the cues to recognizing emotional maltreatment? All of these are diagnoses. Well, a few of these are diagnoses, and others are signs and symptoms, but I also wanted to look at regressive behaviors in the same slides as well. So when we see children developing eating disorders at a very early age, and thus not being able to meet their optimal weight gain in every cycle for each age, when children start to develop speech disorders from normal language development. So all of a sudden they start to have speech latency, speech delays, and then a full-blown speech disorder. You're looking into emotional maltreatment that is only visible through that particular diagnosis. Now again, these are points of further assessment, further investigation, so not necessarily one translating into direct emotional maltreatment. We're looking at developmental delays in speech and motor skills, cognitive delays. We're looking at height and weight below norm. So again, especially weight being tied in with eating disorders. We're looking at flat or bald spots on the infant's head, where, you know, because of stress, they're losing hair at a very early age. And if you see it not being caused due to a medical condition, so of course, if a child is tried for all other medical conditions that could cause alopecia at an early age, and then, you know, the results coming negative, and then noticing a pattern of stress, and then that followed up with loss of hair. That's an indicator. We also look at nervous disorders, head banging, that's a very clear indicator, especially in younger children. And then looking at some of the regressive behaviors, poor peer relationships, depicting cruel behavior to other children, to pets, and to animals. We're looking at behavioral extremes, age inappropriate behavior as far as sexuality and emotional maturity is concerned as well. And then overall withdrawal from society. Now, it's important to remember what we talked about earlier, where children can internalize and externalize behaviors. So remember that eating disorders, speech disorders, developmental delays are all a result of internalization of those stressors. What are some contributing factors to child maltreatment? And again, we're looking at the full broad category. And to answer this question, it's actually really tricky because it's complicated, and it's usually the result of an interaction of personal, interpersonal, and environmental stressors. And we are looking at different factors for each family. Each family has their inherent strengths and their capabilities that can be developed to prevent future maltreatment. And therefore, it's difficult to say that the answer is the same for each family. Just like that, every child has different resilience factors, different inherent strengths and capabilities, and every child gets impacted from maltreatment in a different way. We're looking at 4 categories in general. The contributing factors to child maltreatment can be divided. However, to specifically pinpoint what could be the contributing factors to child maltreatment, I have divided the content into 4 categories. The first one is personal characteristics of the parent or the primary caregiver. The next one is the lack of resources and a support system. Then special or unusual needs or characteristics of the child. Then excessive stress in the family and the surrounding environment. So looking at the first one, which is the personal characteristics, we're looking at very limited coping skills, in fact, very ineffective coping skills of the individual. There is difficulty in forming interpersonal relationships. And again, remember that these are the personal characteristics not of the child, but of the parent or the primary caregiver. What puts them at causing this risk to the child? So we're looking at their characteristics. And for a caregiver or a parent, we're looking at limited and ineffective coping skills to deal with overwhelming or stressful situations when that parent or that caretaker does not have the ability or the capabilities to deal with anxiety, with stress, with depression, or any other mental health conditions that they may be suffering with. They have difficulty in forming close relationships. They lack empathy for the child. They do not recognize the need of the child. And earlier I said it's difficult to answer the question about what could cause, what could be the contributing factors in causing maltreatment to the child. It's because every child is different and every child's needs are different. So when a parent or a caregiver is unable to recognize those unique needs of the child, they're lacking this empathy for them, and then that puts them at a greater risk for causing this kind of harm to the child, especially if they're not aware of their needs. We're looking at impulsive characteristics where they're unable to take responsibility or they're unable to delay gratification. So this ties into one of our very earlier lecture about parenting when I talked about delayed gratification, where I talked about the study of, when I talked about the marshmallow study of how delayed gratification is really a key of success in several aspects of life. You're born with it, but you can still learn it. And unfortunately, we see that not being able to delay gratification also impacts parenting, also impacts caretaking of children. We're also looking at a personal history of victimization, and that could also be a baseline for a parent or a caregiver, where that then impacts their further interactions with their own children. Then we're looking at a lack of resources and support system, poverty being number 1. And that is why, like I said earlier, poverty is not just about money. It actually impacts so many other aspects of your life, especially when you're looking at building resources and support systems for parents, for them to be taking care of their children, for caregivers to take care of children, and making sure they're meeting the responsibility. If they are surrounded in an environment of poverty, then that makes it that much harder because you're not getting access to those needed resources, to those needed support systems. Poverty also is impacted by unemployment. So chronic unemployment is a big problem, because then that means that the parent, the family, the child is not getting access to those needed resources and the support systems. We're looking at extended family friends not having them nearby. So if a family is relocated to another distant city or state or another country, and not having those extended family members to rely upon to provide a sense of support, even if it's supports from words. Not having access to that can really put a lot of strain on the parent to be able to cover at every direction in all aspects. When a family actually does not know how to use communities given support. So we often tend to see that in medical situations where individuals are not necessarily aware of the grants, the programs that the community has to offer for medical aspects. We also have a position in healthcare industry known by the name of community health workers, who offer, who are basically individuals that decrease this gap between facilities and healthcare access to, and people. So they decrease this gap by providing this information about community supports to individuals who need it the most. Now, when there is a family who may not know about those community supports, that puts that much additional strain on the family to then make up for those resources on their own. So having information about this is definitely helpful. And then limited choices to solve problems. Unfortunately, there are often times when there are issues, when there are problems that needs to be solved, and there are not enough choices and there are not enough options to look into, and that could impact that could be impacted by the lack of resources and the support system. Okay. So the unusual needs or characteristics of the child. When I was talking about it earlier, I wanted to give a more specific focus to this particular area. When a child is sick or born prematurely or has developmental delays or is medically fragile, they do require a high degree of care. And oftentimes it can be stressful, it can be overwhelming for whoever the caretaker may be. It could be a parent, it could be anybody else. But taking care of a child that is sick, that is suffering from those delays or another medical condition, it is a more time requiring job that comes with its stresses. And not being empathetic to that can really put the caretaker in a position where they're not sensitive to the child's needs, so they're not sensitive enough. The child's condition does place a high burden of care, of family's time and resources. So we're not just looking at time, we're also looking at money-wise. It's much more, it takes more money, and money-wise it's more straining as well. Parents receive the child to be different and having undesirable qualities. And what do I mean by that? So when the child does suffer from any of these conditions, unfortunately, oftentimes we tend to labelize things. We tend to labelize people. And the label of being different doesn't necessarily have, it should, but that label of different then has that negative connotation for families that this child has undesirable qualities, and that's why they're more straining as far as time and resources are concerned. And when the parent or whoever the caretaker may be for that child who has those additional needs is not empathetic enough, that puts the child at that risk of abuse and neglect. What could be causing excessive stress in the family or in the surrounding environment? A family being in physical and frequent crisis. It could be due to unemployment. It could be due to natural disasters, illness of family members, losing a loved one, family residing in a unsafe neighborhood, in fact, a violent or threatening neighborhood, racism and discrimination that could also limit choices and increase stress. We have several studies that prove that racism and discrimination tends to increase stress at a very young age, and how that impacts the adult health and financial economic well-being outcomes during adulthood. We're looking at recent losses, could be in the form of death or divorce, frequent relocation, a family residing in a very isolated remote area where they do lack transportation to connect to the other community members or to facilities or to other family members even. So not having access to transportation could also put a family in trouble. What are some of the risk factors for child abuse as far as a child's characteristics? And unfortunately, we do see that every additional need for a child does put them at a risk. So premature delivery, having a child who's colic at a very young age, where what exactly is colic? Where it cries for a 3 to 4 hour episodes that causes a lot of distress among parents, among caretakers. Physical disabilities, developmental disabilities, a chronic illness, emotional and behavioral disabilities, and unfortunately, a child being unwanted based on gender as well. And we do see cases where, specifically the girl gender, the female gender, who's deemed an unwanted child, and that's why the parent or the caretaker may not be as empathetic to their needs, perhaps to they would be to a male gender, a child of male gender. So physical exams usually are the ones that raise the red flags, and they're usually the most common indication of physical abuse. One common example would be bruises that occur in children that are less than 6 months old. That would cause a red flag because bruises are very uncommon in infants. There's a very common saying about it: those who don't cruise rarely bruise. So if these children are not mobile because they're less than 6 months old, how is it that they're falling through the stairs? How is it that their hand gets stuck into the crib? They're not moving, so how are they getting bruised so quickly and so frequently? That's definitely a red flag. And also, it's important to realize the characteristics, two characteristics that separate abusive from accidental bruises, and that is location and pattern. Medical professionals are the ones that have come up with what are considered these red flags of child abuse, and it actually occurs in more than 50% of the abused children. So it's very important to take a note of these locations and these patterns. So I have this chart for you where everywhere an accidental injury would occur versus an abusive injury would occur. So a very good example would be an accidental injury would occur on the forehead, where a child bumped their head into the crib or into the wall. They bumped their head into anything, whereas the abusive injury would occur on the face, because it's much more common for a child to get injured on the forehead than onto the face, especially if it's on the face, then looking at the injury patterns, the injury markings, and what those look like. Another very common example would be hips versus butt area, where hips would be accidental, abusive would be the butt area. Then also under chin versus neck. So that's a very common one as well, where the under chin is the accidental area, but the neck itself is the abusive area. It's important to kind of go through all of these. These make excellent exam questions as well, especially for multiple choice, FYI. Looking at the next lecture. So our next lecture is going to be focused on ethical aspects of child abuse and neglect, a duty to report, policy preventions and interventions, and etc. So I know this was a longer lecture. We had definitely a lot of content to cover in this lecture, but it kind of encompasses everything that you need to be aware of as far as child abuse and neglect is concerned. And this is just a introduction to everything that also is going on out there that you should be aware of. So the lecture in combination with the documentary, with the supplemental material, will really provide you with in-depth information that you need to know on this broad and very vast topic. If you have any questions, don't forget to shoot me an email through my SFA or through the D2L.